In 2008, Professor Sawyer was awarded the Medal of the Order of Australia for services to the field of child-adolescent mental health and as a researcher and educator. He led the investigation into the child-adolescent component of the National Survey on Mental Health and Wellbeing in Australia and the Beyond Blue Schools Research Initiative. And he's currently a life member of the Australian Rotary Health, and in 2003 was one of the first recipients of Australian Rotary Health Medal. Thank you. Professor Michael Sawyer.
Okay, what I'm going to do is tell you a little bit about child and adolescent mental health in Australia and what the issues are. And there are two ways you can go about understanding this. One is from the individual perspective of children and adolescents who have problems in the area, and the other is at a population level. What's the size of the problem? Is it something about which we should be concerned? And I'm going to try and briefly cover both those at the present time. So let me tell you first of all about two children who were sent to me to try and get help with their problems. So these are real kids. I've obviously de-identified them to ensure no one knows who they are, but nonetheless they're very real. So the first child, Jane, was 16 years old when she was sent to me for an assessment of her anxiety and her depression, which she'd been experiencing for some years. At the time she came to see me, she was in year 12 in high school, and she was living in the home of her best friend. Jane's parents had separated and she had had little contact with her father for many years. Her mother had a history of drug abuse, and much of her childhood had been cared for by an aunt. She said that she thinks the anxiety that she was experiencing when she came to see me began when she was roughly about 8 years, when it seems that she probably experienced a home invasion which was related to her mother's drug abuse. She couldn't remember the details of it, but she remembers it as being a frightening time at night when she was alone, and also having to care for a younger sister. She subsequently experienced quite a lot of domestic violence too, because her mother tended to have boyfriends. If you have any dealings with the drug trade, you know it can be quite violent, it's very transient. And remember, Jane did not choose this family, just as a little aside, and I'll come back to that point. It's luck of the draw, folks. She didn't say, I'll take that family. So at 9, she sees her mum being physically attacked. She said she had to protect her kids, her sister, on a number of occasions. And then over the next few years, her problems escalated. And so here's a sort of outline of how I think about kids in Jane's situation. So this is good quality of life, poor quality of life. Here's Jane tracking as I've been describing so far. The way it works is we get genes when we come into existence. We get conceived, we get given a set of genes. And I think of it like we're in a big queue. We head towards that conception. A wheel spins, lottery of life, number goes up, and you get a set of genes. You have no choice whatsoever. Jane had no choice in deciding what genes she was going to get. You pop out into the world, and you have the two people, or perhaps one if there's already been a separation, who gave you those genes. Now, the rules of the game are you can only travel left to right. You can never stop. You simply keep progressing. You can't loop back. There's nobody here going to be 21 again, folks. You know, that's it. And as you travel, there are little intersections, I think, of all the time where you make choices. When you're little, your parents put you on a line. As you get older, you get some control of the steering wheel. Up here is parental fighting and mental illness, of which Jane had stacks. It weighs you down. Okay, so it pushes you down. Hard to fight against that. If you're lucky, and here's where Jane was working hard, you get some educational success. That will tend to increase your chances of angling your road up a little bit. So now Jane reaches around about 10 years or so. Here she is about here. And she begins to experience social anxiety. Anxiety is chronic, but it tends to change its face over time. So she becomes increasingly anxious when she's with other kids. She got a bit of counselling from a psychologist. Trouble with the psychology appointments is it's difficult to get appointments that are close together. It tends to be spread out over a year or so. And she was hanging on by her fingernails with her school at that stage. In the past, she said she'd had energy. She'd actually had part-time work for a period of time. But she was at this stage really beginning to struggle because the anxiety was really getting on top of her. Didn't smoke, didn't use alcohol, didn't use illicit drugs. The things over which she could try, and she was hanging on there as best she could. Jane has a condition called social anxiety disorder. So real person, that's one of the kids I saw. Another boy is John. Here he is. So John comes into the world, he gets his genes, he pops out and he comes into a family. He was sent to me at the age of 5 years because he was exhibiting major problems with his behaviour and had actually been moved, even at that age, into a special school setting. Got a younger sister involved with his mum with home duties. Dad works as a manual labourer. When I sit down and speak to Mum, she tells me she had him when she was 15. So she had a child at the age of 15 years old. So John pops out, again, no choice. He didn't sort of say, I'd really like to be in a family with a 15-year-old mother who, as it happened, had quite severe depression and spent long periods of time in bed by herself. Much of his care was provided for a grandmother, by his grandmother. And his mother kind of said that she didn't bond very well with him. So that you've got a child popping out here. That bonding isn't just of academic interest. That's a wonderful period of time. Infants pop out, a computer turns on, and they start looking for a face. They start looking for a primary caregiver. John's mother didn't respond. So that magic dance that goes on through that first year or so, when we develop the capacity to relate, respond, reciprocate, he missed out on. So it's not surprising to discover that as time went on, his ability to manage his anger, to work relationships, even at the beginning, was really quite poor. Mum said that Dad, she thinks, might have had attention deficit disorder, but he was an odd sort of fella who lived in his shed, spent long periods of time out the back. And she said there were lots of arguments between her and him over a whole range of issues. And here's this: if you want to know what's toxic for kids, it's fighting. You know, we all got excited and went up and did things in Port Pirie for lead. If you ever look at the causal charts up there, the things that were having the big impact, it weren't the lead, it was the fighting in families, stuff that goes on under roofs that you never see. According to his mother, the behaviour problems, as I said, were evident. He was starting to have difficulty sleeping. He was bouncing around the place. Ended up spending 2 days a week in childcare, in primary care, aggressive to other children. If you start at 5 in primary care, if you come into school and you're not doing well and you're exhibiting behaviour problems, you're in real trouble because it predicts a trajectory of problems. It's not just that 1 year, because the teachers talk to the next teachers. Somebody else comes into the class and they're bright and they're doing well. It attracts the interests of the other teachers. We can begin now. We've done it. We've tracked some of these kids over time in looking at what goes on. And he'd even been suspended on a couple of occasions at 5. Oppositional defiant disorder. So, you know, that's another one of these conditions. Now, if we're going to have a well-educated, self-sustaining and productive society, we need to have waves of kids coming into our society who are healthy and well-educated. If we don't have that, we can't have the sort of society that we would all like. In South Australia, we have about 20,000 births per year. So we effectively have about 20,000 new citizens who come into South Australia every year. It's about 22% of the total population under 18-year-olds. Now, there are 3 things that you need to understand for the rest of the talk. One is, what are mental health problems? People use this term of mental health problems. There is no exact definition of mental health problems. They're used to describe alterations in thinking, mood or behaviour associated with distressed or impaired functioning. So it's a very general term that gets used. Another term is mental disorders. Now, this is a very specific term, so also characterised by clinically significant sets of symptoms, emotional behavioural problems associated with personal distress and impaired function. But in this case, very carefully defined. So if you go into any hospital or health setting, you will find they've got somewhere lists of conditions from which we suffer: diabetes, asthma, cystic fibrosis, and mental disorders. The mental disorders section will include definitions, because we still don't fully understand the pathophysiology of many of these conditions. We know they exist, we can describe them. What I'm going to be talking about today are these carefully described and researched conditions, of which I've described to you one girl with social anxiety disorder and one boy with oppositional defiant disorder. The last term you need to understand is this terrible term, disability adjusted life years. This is trying to measure what conditions take away healthy years of living. Now, this concept wasn't developed by mental health people, psychiatrists, psychologists. This is World Bank. World Bank in the 1990s, becomes interested in what are the things that take away productivity from communities. They reason that poor health is a likely candidate. They employ some absolutely outstanding epidemiologists who say, well, look, we need to not only look at things that kill us, we need to look at conditions where we have to live with them for a long period of time, because that's likely what affects individuals, families, and our community as a whole. And they developed this concept of looking at what they called Daleks, but the simple way of thinking about that is years of healthy life lost. It turns out, over the next 15 years, we find, as a result of surveys in Australia and internationally, that child and adolescent mental disorders in particular, so these are the disorders, have a high prevalence, a substantial impact, and they persist. All of a sudden, we discover something that nobody knew prior to that time. When we were setting up health services, all we knew was some kids came to psychiatric clinics, they seemed to have funny problems. We had no idea how many there were. Most recent survey in Australia, so it's a national survey, randomly selected kids from across the country. About 14% of young people have a condition that meets a mental disorder criteria. That means in South Australia we're talking about 38,000 kids with conditions of this type who would have histories similar to what I've described. I mean, they vary a bit. You don't know this because it goes on under roofs. A little while ago, I drove up through Salisbury and Elizabeth, some of the most deprived settings in Australia. I didn't see anything different. I mean, the grass was green, the freeway took me through all right. But you go out and count and go into the households and you'll see the sort of things that I'm talking about. The worry is the prevalence of mental disorders, mental health problems, is not declining. We've just done work comparing rates in 1988, when the first survey was done, with 2014. You know, you might argue that in a few areas, maybe among girls, there's a bit of an increase in depression in adolescents. It's trivial in terms of it's still 14%. We're not cracking it. You know, we're not looking after those kids and bringing them through in ways that are going to benefit them and us. So here's the prevalence in South Australia. So here's anxiety disorders, here's Jane, about 19,000. You know, whether it's 18,000 or 20,000 is small in the scheme of things. It's a common condition which is adversely affecting every one of the kids who's got it in the way that I described Jane. ADHD 20,000, depressive disorder 7,000, conduct disorder, very severe misbehaviour, not John, worse than that, 5,000. So we're faced with a significant public health problem that we've now counted and identified. Here's the Daleks. So what are the things that take away healthy years of life? So something like 30%, 15 to 14-year-olds, of years lost are due to this mental substance abuse, combination of parental substance abuse and mental disorders. Here's the chronic respiratory disorders, around about 12%. This has now been a stable result that's been identified over the last 15 years or so. This is where the healthy years of life are going amongst those 20,000 children. Here's 15 to 19-year-olds, 30%, solid figure. It's a huge problem out there. That's what's going on. It affects not only health services, education services, justice services, social services. And not one of these kids chose to have the family or the genes that gave them this condition. The other thing that's become apparent in recent years is the age of onset is much earlier than people understood. Something like 50% of mental disorders onset before 14 years. Something like 75% before 24 years. Now, we've had great advocacy in Australia for this period of time. This is Pat McGorry and a whole lot of people. Another $50 million went to Headspace in the last week or so. We really tried to go after that adolescent 15, 20, 25 age group. What we haven't done, in my view, is tackled this, the 0 to 14. This is where Australian Rotary Health is starting to say, we need to pay more attention to that. And this number is worrying, because once these kids get things like anxiety, it sticks. Oppositional defiant disorder increases your chances of this very severe conduct disorder massively. We don't want kids coming up with that. across all the age groups. So this is not just children. You know, you would have heard this, the 1 in 5. So here's the anxiety disorders again across all age groups, major problems, depressive disorders, substance abuse disorders. So this is not just a problem of children and adolescents, it's across all the groups. Everyone here will know people with a mental disorder of some kind. They might not have told you. Kids with obsessive compulsive disorder and some of these conditions keep it fairly hidden, but more and more, as people are willing to say, just as they might diabetes or asthma, you'll know someone. The prevalence is too high for you not to know people. Here's the Daleks in terms of lost years. So here now is 15 to 49 years. It still sits at about 30%. So we're talking about the period of time when we develop skills, when we become educated, and when we become productive members of society. The World Bank spots something like 30% of those years have been taken away by these conditions. That's why you're seeing governments get so interested in this. It's not altruism. World Bank, I had a friend who worked there, wall-to-wall economists, you know, not wall-to-wall altruistic people interested in touchy-feeling things. They're spotting this and saying, look, we've got to do something about this. And then, of course, as you move into the older age group, the mental disorders fall away, but your cancer, musculoskeletal disorders, cardiovascular disorders start surfacing. So all the healthy years of life lost to adults across all the areas, and it's purely by chance we get another 1 in 5, but about 1 in 5 of those healthy years being taken away are due to mental disorders. This is the population level, so that's complementing what I told you earlier on about a couple of individual kids who make up this population. Don't believe me? Go here. It's on the website. This is not psychiatry or psychology advertising this. This is a very good website, WHO type work. You can go in and you can work the numbers and the layouts to have a look, and it's actually, it'll be on here because you've got my presentation. ARH has said, this is Australian Rotary Health, we're going to try and back research. We're going to try and do something about research in this area. Why research? Why not services? Services, I'm afraid, are just too expensive. You know, these are billion-dollar exercises to try and come at this. But the point of research is to develop new knowledge. I mean, people think research and science, it must be mysterious. It's just developing new knowledge, you know. And is it important? Well, you know, we're coming up to the armistice. Think back 100 years. If you got gangrene, you were in trouble. You know, you lost your leg and your arm. There were no antibiotics around. If you got diabetes, you died. And it was as simple as that. That changed because people started saying, we're going to try and generate new ways of helping. We're going to try and develop new skills of treatment. And we changed it. And the challenge is to do the same thing here. We're faced with a common problem with severe impairment and deaths. You know, the suicide rates amongst these kids is high. The difference between suicide rates in depression and non-depressed population is enormous. Research also, as ARH knows, promotes staff development and professional standards. Teaching hospital CEOs like it because it attracts staff, plays a significant role in attracting staff. Occasionally, economically, it contributes as well. But the key issue is it's generating new knowledge. Hospitals with long traditions of excellence have demonstrated absolutely the research enhances the vitality of teaching, teaching lifts the standards of service, and service opens up new avenues of investigation. That's why you want to try and keep that balance going. Very hard in the current climate. RAH, where you're working under enormous pressure in terms of providing just service, trying to keep this alive is where I think is the most important work to be done. Here's ARH. So what it's done, Australian Rotary Health has had a portfolio of activities, so it's mental health grants, PhDs, this is where they learn to do research, postdocs, where they learn to manage research, and this wonderful Indigenous Health Scholarship program. That's the sort of portfolio to try and generate this new knowledge. Can it make a difference? Well, you know, Philip Hazel with medication, Sophie Havinghurst with preschool children, Prof. Jane Perkis reducing, so it really can make a difference. And, you know, there's not time to go through these studies, but they're just some examples of work that was funded by Australian Rotary Health. We're trying to change the trajectory. We're trying to pull Jane and John out from down here and lift them up to have a decent and reasonable quality of life that would be comparable to children who have not had the experiences they have. So think about joining the campaign for research, for training, for awareness. Very much by Australians, for Australians. From time to time they have these activities, round Australia bike rides and this sort of safari. I got dragged into to to this, dragged in. I mean, here I am at the university telling me I should take holidays, bike ride, chairman of the research committee. I thought, well, maybe Adelaide to North Adelaide, I haven't done a lot of bike riding. I ended up doing Melbourne to Adelaide to Melbourne for reasons that still sort of escape me somewhat, but nonetheless. And so just to prove it, here's me getting ready for the bike ride, there I am thinking my way through it. Here's what they sent my wife about halfway through the bike ride, just to let her know that I was fit and well and coping all right. And here's me at the end. My body has come under a bit of doubt in recent times, but nonetheless. So that's the story. But just to bring you back, I just want to give you one quote to remind you of the beginning of this talk. This is from All in the Barley by Melissa Harrison. It isn't easy to conceive when you're growing up that the world could be any different than how you find it. For the things you first encounter are what normality comes to consist of. And only the passage of time teach you that your childhood could have been in any other way different. That's what it's like for these kids. So, thank you. Sure.
Has anyone got any questions for Professor Sawyer? Jeff?
Thank you for a wonderful talk. Is actually one question I have for you is actually related to those children who actually don't choose where they actually were born and those things. We have a lot of experience with refugees who actually come to our club and are involved in our club, and these children like Eliassi, who spoke last night, who despite adversity takes a pathway that actually just rises as your graph goes without any other reason. And you actually see that in a lot of families. I see it a lot in the Theban community related to refugees who seem to have a terrible adverse childhood, lots of problems, but they seem to rise above it without any other thing. Is there any research or anything been done of why this child you pick, who actually has all the disadvantages of the world, but actually seems to rise above it and actually makes an absolute success of himself?
I'm not an expert in the area of refugees and refugee children, but what you don't see is all the children who haven't risen above it. So it's a bit like prevention. They talk about how hard it is to get farmers on side with prevention. I remember hearing a scientist say, well, one of the problems is you can't stand at the top of the hill and see all of those plants that were playing havoc not there. And so what you don't see is the children who didn't make it here. The rates of mental health problems among some of those refugee kids and some of those areas where there's been wars in particular are prodigious. And occasionally I've heard presentations from these absolutely outstanding people who are working in these areas. I mean, I was with a group of people who are working with, favelas, the Brazilian drug areas that have been taken over. And there was a woman from India, and there were a group of people who were looking after kids in Lebanon. So, I mean, I fear what you see is some of the survivors who have managed to make it through. You don't see the ones who died and had all sorts of problems who perhaps are still there.
I was on the board of Hillcrest Hospital for 10 years, and I was its last chairman. And when we were disbanded, it was taken back by the government department and stayed like that for many years. Hillcrest was eventually demolished and is no more. Today those patients are in our general hospitals. It was closed because the worldwide trend was to close mental institutions. Is it now time to revisit that question and to have specialised hospitalisation for people with mental health problems?
Talk at length about that. Where I get cross is how little of these policy decisions are driven by plausible evidence of their likely effectiveness, and how much is driven by political nuance and economic considerations at a particular point of time. And I think that's what I would say in relation to that.
I guess my question's on related lines. You did make a fairly strong emphasis on genetics, but is it genetics or environment? And do you need to actually do something to circuit break the environment these people are in? I guess my only experience in this is having been involved in Operation Flinders for many years, where we used to take kids around the Flinders Ranges, and I mean the effect was cathartic. But you show them an alternative, albeit somewhat briefly. And the fear was always, well, if they descend back into that same environment, what chance have they got?
It's both. It's as simple as that. It's both. It's a combination. If you're born, I mean, let's pick Jane. So Jane has a loading of anxiety problem, of anxiety genes. But if she gets into a supportive, helpful family, her likely outcome is completely different. And also, of course, you get born into the family who gave you the genes, or the parents who gave you the genes. It's not one or the other. It's a combination of both, and how they interact and how that evolves over time.
Do you find that most social issues are the cause for mental health issues?
They certainly play a role, but as I was emphasising at the beginning, the biggest issue is what goes on under the roof of the home. That's what I was really emphasising. When combined with genetic influence, yes, the social influences are another element of it all.
So do you feel that these people have to be taken away from their current circumstances so that they have a better chance in life?
Which people?
These people with mental health disorders who are in social deprived circumstances.
The difficulty is that the state, the governments in all countries have not proved very good at that. Generally, it results in people going into worse circumstances. I think I could defend that statement pretty well. You could think of Indigenous population, but there are a lot of other populations. Think of child protection at the moment. I tell all the kids I see who are in difficult families, the alternative of being out is almost certainly worse. We're not very good at providing an alternative. In fact, we're lousy at it.
Just one more question, Stephen.
Yeah. Can I just firstly say I thought it was an excellent presentation. I've got a question, but also I want to preface the question by saying that a lot of children are born into really loving family environments, and they still end up having problems perhaps with dependency, drugs, etc. But my question was more around the autism Asperger's spectrum, and is that defined as the people that you refer to in those statistics, or could you elaborate a bit on that? Because to me that seems to be the genetic lucky draw or unlucky draw.
In response to your first question, there are some, of course, who are born into loving families who don't do well, but the probability is much less. If I have 100 children, 100 of those 20,000, and I pop them into loving families, there will be some who develop depression and anxiety. I take 100 children and I pop them into families of the kind that I described to you at the beginning, there will be a large number more, vastly more. It's that's the lottery, it's a chance thing. Asperger's, well, autism, ASD, autism spectrum disorders at the moment are undergoing revision. I mean, when I was training, the condition was described in quite a tight, well-defined way. There's a lot of politics around what the boundaries are. NDIS is reviewing what the criteria are going to be. There's a disorder in there, but I couldn't respond in a minute or two. Simply that the boundaries of that at the moment have varied according to a range of different circumstances. But if you see a child with autism, you'll never forget it. I don't know whether people have seen children with autism, with language disorders. I mean, those children have a condition that really doesn't require a psychiatrist to sort of say something's going on. It's just the boundaries get really fuzzy for all sorts of economic and other reasons.
Thank you very much, Professor Sawyer, for your wonderful talk. I think everyone here's got a huge amount from that and will understand some of the problems that are out there that have to be dealt with. And in appreciation, we give you this wonderful pen. And I just want we've got the Australian Rotary Health have these tins that if you've got a business, you can sit it on the shelf there. So if you want them, I can get them for you.